Welcome to the Deep Dive, the place where we take complex topics,
Yeah.
massive piles of research, and distill them into the kind of essential, memorable knowledge that truly makes you well-informed. Today, we're peeling back the curtain on one of the most vital and, frankly, most stressed professions in modern society, nursing.
It's an immense field, and it's so much more specialized and, historically rich than most people realize.
Absolutely.
We are going to be tracing the profession's journey from these sort of informal ancient healers all the way to the highly specialized, data-driven experts you see running, say, a modern critical care unit.
And to do that, we've pulled together a whole stack of sources. We've got historical lectures, biographical material, and then we have current professional standards, ethics documents, even academic research on education and safety.
A really wide range.
Our mission today is pretty straightforward. We want to trace in detail how basic, often informal community caregiving transformed into this rigorous, specialized profession. Get this, currently has 4.7 million registered nurses in the U.S.
That number alone, 4.7 million, it's just staggering.
It is, and it tells you the immense scale of this workforce.
And it's so crucial to grasp that scale because understanding the professional foundation of nursing is absolutely key to appreciating its current impact and, I think critically, its future needs. To put this in some stark context for you, nursing is the single largest group of healthcare workers in the United States. And that workforce is under some profound strain right now.
You hear that all the time.
Yeah, and here's a statistic to back that up. The median age of an RN is 46. And about a quarter of that entire workforce plans to retire within the next 5 years.
Wow, a quarter. A quarter of 4.7 million nurses are planning on leaving the profession in 5 years.
A quarter.
That demands an equally massive influx of highly trained new entrants just to keep the system stable.
Exactly. The stakes for the future of healthcare really couldn't be higher.
They couldn't.
Okay, so let's unpack this, starting with where this specialized role first began to take shape centuries and centuries ago.
Right, so when you look way back at early history, the concept of a nurse, as we know it is, it's just not there. Our sources say that in ancient times, the role of providing basic medical care was often, and this might be surprising, male-dominated.
Yeah, that does surprise a lot of people. You're talking about, simple healers or maybe priests who manage sickness as more of a spiritual problem.
Or guys who were just good at mixing up potions in herbal concoctions.
Right. Caregiving was essential for survival, of course, but it operated completely outside of any kind of formal training or standardization. It was very localized, often mystical.
And then things start to shift a bit.
They do. As societies developed, religious orders began to play this huge centralized role. They saw caring for the ill, supporting the dying, providing maternity support. They saw it all as a sacred duty.
So this is more like institutionalized care.
Exactly. Often provided by nuns or other members of the church who, in addition to spiritual guidance, were offering this early form of community-based care.
And then, as always happens with huge historical events, when the formalized systems break down, especially during a war or a crisis.
That's when you see the rise of the volunteer.
Right. This was so clear during wartime. The Revolutionary War, the Civil War, even into the World Wars in the 20th century, people just volunteered to help the sick and wounded.
And they were relying on just common sense, intuitive caregiving skills. Changing dressings, feeding people, providing comfort, but with absolutely no formal training. None.
That reliance on well-meaning but totally untrained volunteers really highlights what a radical transformative change was coming.
It does. Because formalized nursing education, as we'd even begin to recognize it, only really started to emerge around 1872, so late 19th century.
And that shift wasn't just because people suddenly became more compassionate.
Not at all. It was driven by the crushing reality of death rates and, most importantly, by early breakthroughs in science.
The integration of science, or this, empirical observation. That's the key step that separates nursing from just basic caregiving.
It is. Our source material points out that the single most critical evolution in all of healthcare was the dawning realization of how germs spread.
The germ theory.
Exactly. And that realization led directly to establishing these, rudimentary hygiene practices, hand washing, cleaning wounds, and critically cleaning bandages instead of just reusing dirty ones.
Which sounds so obvious to us now.
But that realization that cleanliness was directly linked to less sickness, it was met with just profound skepticism by the medical establishment at first.
Right. Wash your hands. What for?
Pretty much. But the empirical evidence, the data, eventually just became undeniable.
And if you just try to visualize the physical environment of care back then, it's so clear why infection rates were catastrophic.
Oh, absolutely.
The sources describe these early hospitals. They use examples like the Waverly Hills Tuberculosis Sanatorium. And we're talking about huge open wards, 20, maybe 30 people just crammed into one room.
Zero privacy.
None. And the patients were getting most of their personal attention from the nurses because families didn't really visit that often or stay for long.
Yeah.
I mean, it was an environment just perfectly designed for disease to spread.
And that environment brings us to the pivotal figure who just irrevocably changed the nature of care, Florence Nightingale.
Of course. The lady with the lamp.
We all know that famous nickname from her making rounds at night. But her true impact was profoundly scientific and administrative.
She's really the architect of modern nursing. She brought structured rigor to all of that chaos. So what was her background? What prepared her for that?
Well, she came from a privileged background, but she sought out serious formalized education, which was very unusual for women of her class. She specifically trained in Germany at Kaiserwerth.
And that gave her the framework.
It gave her the framework for systematic observation and administration, not just, basic bedside care. So when she was recruited by the British Army during the Crimean War, the mortality rate in the military hospitals was staggering. About 40% of admitted patients died.
40%. I mean, that's just an astonishing failure of institutional care.
It was. And through these immediate, fundamental, and really data-driven reforms, she focused relentlessly on sanitation, ventilation, clean water, proper nutrition, meeting both the physical and the social needs of the soldiers.
That turned it all around.
She managed to bring that mortality rate down dramatically, all the way down to just 2%.
Wow. And this is before antibiotics.
No antibiotics. She had cleanliness and organization.
That reduction wasn't magic then. It was the direct result of empirical observation. It was evidence-based action before that was even a term.
Yes. She introduced the concept that guides the profession today, emphasizing, and this is a quote, "What you want are facts, not opinions."
Facts, not opinions. I love that.
She stressed teaching nurses what and how to observe for objective signs of improvement, or, on the flip side, clear signs of neglect. She was gathering data, charting outcomes, and proving with hard, quantifiable evidence that changing the environment saved lives.
And crucially, she didn't just stop there. She leveraged that success to secure lasting funding and write these foundational books on nursing care and creating safe environments.
She wasn't just a compassionate woman with a lamp. She was a brilliant administrator and epidemiologist, a reformer who established formalized training programs, transforming nursing from this kind of charity role into a rigorous, educated field.
And the revolution she started didn't just stay in those military hospitals, right? Her legacy and the work of others, it expanded way beyond the hospital ward.
It did. The Crimean War also highlighted other key figures who expanded the reach of nursing. We have to talk about Mary Seacole.
Okay, tell me about her.
She was a Jamaican nurse who was working at the same time as Nightingale, but she focused heavily on outreach nursing services directly in the community. So while Nightingale was fixing the system inside the barracks, Seacole was out on the battlefield, setting up centers, providing hands-on care.
So she recognized that care wasn't just needed behind these bureaucratic walls.
Exactly. And that idea of resourceful, community-based support that really defined the American Civil War era. Clara Barton, famously known as the Angel of the Battlefield.
Right, the founder of the American Red Cross.
Yes, and she didn't just care for the wounded. She founded the American Red Cross by adapting the international model to the U.S. And she focused on this massive logistical challenge of managing and distributing essential resources.
Like what?
Things like food, clothing, and of course the blood drives the organization is still famous for today. She basically managed the supply chain of humanitarian aid.
Incredible. Another essential figure from that same conflict was Dorothea Dix.
Yes. She helped found the American Army Nurse Corps during the Civil War, organizing the Female Corps. But her enduring and maybe most important legacy is her relentless advocacy for the mentally ill.
She campaigned for humane treatment and institutional reform all across the country.
And it's such a powerful connection to the present because our sources note that mental health and psychiatric nursing is still a critically hot area for nurses today. It requires very specialized training, and it often operates outside of that traditional hospital framework.
We should also take a moment to acknowledge the bravery of Susie King Taylor. She's noted in our sources as the first Black Army nurse during the Civil War.
Absolutely. She represents the vital, if often overlooked, role that Black women played in providing nursing care during the conflict, despite, rampant segregation and just immense systemic challenges.
So these pioneers, all of them, they collectively took care from the battlefield and into the increasingly chaotic and impoverished cities that were growing so fast.
And that set the stage for modern public health nursing, which was driven in large part by two women, Lillian Wald and Mary Brewster.
Right. They established the foundational vision for modern home health and public health nursing in America. The story about Lillian Wald's awakening is so powerful. Her baptism of fire, as they call it.
It is. After she finished her nursing training, Wald was teaching a homemaking class on the Lower East Side of New York City, a place just teeming with new immigrants and profound poverty.
And then what happened?
A little girl burst into the class, begging for help for her mother, who was hemorrhaging after childbirth. When Wald went to their apartment, she found the woman and her newborn in just unimaginable squalor.
And the reason the woman was abandoned, the doctor had just left her there to die because she couldn't afford to pay his fee.
Precisely. That profound injustice, witnessing the human cost of systemic poverty and medical neglect, it fundamentally changed Wald's life and her purpose.
You didn't just write a check or feel sorry for her.
No. She decided to move directly into the Lower East Side to live alongside the people she served. And in 1893, she established public health nursing with the founding of the Henry Street Settlement.
The Henry Street Settlement was part of that larger settlement house movement, which was this progressive reaction to the extreme poverty caused by industrialization and urbanization.
Right. And their goal was radical. They wanted to respond to residents' needs as neighbors, a true community spirit, not just as outside charity reformers looking down on them.
So it became this comprehensive hub.
It did. It didn't just offer visiting nurse services. It also provided clubs, clinics, classes. It basically radiated social work, education, and healthcare out into the community fabric.
It recognized that health doesn't just happen with a single pill or a procedure.
Exactly. This model really solidified the idea that nursing has always involved so much more than just clinical intervention. It addresses the social determinants of health, access to clean water, basic nutrition, education, safe housing.
All those crucial non-medical factors that determine if a population is going to be healthy or not.
And that advocacy role is timeless. It ties directly into why it's so necessary for nurses to engage in policy today. Our sources really stress that nurses are often the first to witness systemic failures.
Like inadequate staffing or a lack of mental health resources.
Exactly. And they have to be empowered to act as change agents.
It's a critical point for you, our listeners, to consider. We ask you to think about this. Do you know who your nursing representatives are in government? Who in your state legislature or in Congress is advocating for the policies that impact the health outcomes you care about?
Advocacy is no longer optional. It's a core professional competency. We saw this so dramatically during the COVID-19 pandemic with the desperate need for proper PPE.
Right. Personal protective equipment.
Advocacy is crucial for securing those essential resources and, on a broader scale, for improving systemic policy, like establishing safe patient-to-nurse staffing ratios.
And it's important to make a clear distinction here for the listener. We've mentioned these different groups. So the State Board of Nursing, the BON, that's the regulatory body.
Right. They issue licenses, they enforce the law, they determine what you need for continuing education.
And then organizations like the American Nurses Association, the AA, or your state's Nurses Association, they're the voice for nurses. They're the ones lobbying for better policy, more resources, safer working conditions.
Exactly. Two very distinct but equally vital parts of the professional ecosystem.
Okay, so let's pivot now to the modern structure of the profession. We established the enormous footprint, 4.7 million RNs in the U.S., about 89% actively working.
Which, again, makes nursing the single largest part of the U.S. healthcare workforce. And the growth projection is just relentless. Estimates suggest about 200,000 new RN positions are created every year between 2021 and 2031.
And that relentless specialized demand explains why the profession's educational pathways had to splinter and evolve so dramatically over the last century.
It does. Early on, nursing really struggled to achieve full status as a recognized profession, partly because there was no standardized way to get into it. This lack of uniformity was highlighted in major early reports, like the Flexner Report on medical education.
So this fragmented entry point started early with the diploma programs, beginning around 1879.
Yes, these were purely hospital-based training programs. They were truly work while you learn. But we need to understand the intensity of that. Students often worked grueling shifts 7 days a week, 50 weeks a year, for 1 or 2 years.
So their labor was basically paying for their education.
That's right. It was intense, on-the-job training. And some of these programs still exist, maintaining that practical focus.
But the push for true professionalization demanded a university connection.
It did. The University of Minnesota established the first baccalaureate program, or BSN, in 1909. The BSN curriculum was fundamentally different. It wasn't just about technical skills. It introduced management, leadership, research principles, and community health.
And the data eventually proved that this higher education was necessary.
It did. While hospital diploma programs dominated for decades, this landmark 2011 Institute of Medicine report later recommended that 80% of all RNs should be BSN prepared.
And that wasn't just an academic preference.
Not at all. It was based on compelling evidence that higher education levels correlated directly with better patient outcomes, especially in complex hospital settings.
But the demand for nurses was outpacing how fast universities could graduate them.
Exactly. Which led to the introduction of the Associate Degree Nursing Programs, the ADN, established in community colleges around 1958. This pathway provided a focused, technical track to get a license, and it filled the immediate need for a large volume of bedside nurses.
So it was a faster, more accessible route for a lot of people to enter the field.
It was. So you ended up with 3 distinct entry points: diploma, ADN, and BSN, which all lead to the same licensure exam, but they provide very different foundations of practice.
And the demand just kept increasing.
It did, which led to specialized accelerated paths. By the late 1990s, our sources point to around 97 or 98 accelerated programs started to pop up. These programs, often 12 to 18 months long, were designed to fast-track adults who already had a bachelor's degree in something else.
Get them into the nursing workforce quickly.
As fast as possible. And then, beyond the initial RN license, the sophistication of care demanded even more specialization. That led to the boom in graduate programs starting in the 1980s.
This is where we see the creation of advanced roles.
Yes, master's and doctoral degrees created these higher-level practitioners. This includes the Advanced Practice Registered Nurses, or APRNs. So you have nurse practitioners, NPs, who function a lot like physicians in diagnosing and managing illnesses.
And certified registered nurse anesthetists, CRNAs.
Right, who provide the majority of anesthesia care in many rural areas,
Wow.
often practicing with a lot of autonomy.
And then you have the specialized doctoral degrees.
You do. The Doctor of Nursing Practice, DNP, which focuses on high-level clinical leadership and quality improvement, and the PhD in Nursing, which is about pure research generation, creating the knowledge that the DNPs and BSNs will later implement.
The whole knowledge ecosystem.
It is. And the reason all this specialization was necessary stems directly from how the hospital environment was changing, especially starting in the 1960s. The establishment of Medicare and Medicaid, plus more employer health coverage, caused hospital admissions to just soar in volume and complexity.
And that era required a radical physical restructuring of the hospital.
It did. It led to the rapid creation of highly specialized, high-acuity units, things like the Intensive Care Unit, ICU, and the Progressive Care Unit, PCU, which require nurses with extremely specialized training.
And the government had to step in.
The federal government had to. The 1964 Nurse Training Act provided crucial federal funds and scholarships to support nursing education programs. It was a final acknowledgement of the direct link between a well-educated nursing workforce and national public health.
And then we hit the 1990s, and cost control again forced a shift in labor strategy.
Yes, the large-scale introduction of unlicensed assistant personnel, UAPs, also called patient care assistants, PCAs, or nursing assistants.
And their role was very clearly defined.
Very clearly. Handling basic tasks and activities of daily living, or ADLs, things like eating, walking, bathing, toileting. This allowed the RN to focus on a high-level clinical judgment.
But this shift required RNs to develop a completely new, high-stakes core competency.
Appropriate delegation.
That's a critical point. Why is delegation so high stakes?
Because the RN, as the licensed professional, maintains absolute legal and ethical accountability for the patient's entire care, even if they delegate a task to a UAP.
So you can delegate the task, but you can't delegate the accountability.
Never. So if a PCA fails to turn a patient properly and that patient develops a pressure ulcer, the RN is ultimately accountable for failing to supervise, assess, or follow up appropriately.
So there's a whole process to it.
There is. The 5 rights of delegation, The right task, right circumstance, right person, right direction communication, and the right supervision evaluation. Misunderstanding any of those rights exposes both the nurse and the patient to significant risk.
And the overall trend we still see today is high census, high patient acuity, expanding beds, and just intense specialization.
And the nurse is the pivot point managing all of those inputs.
So we've established that nursing is a highly specialized profession, not just a trade.
Yeah.
But what is the philosophical, the functional definition that defines this scope?
Well, the American Nurses Association, the professional voice for nurses, defines nursing as integrating the art and science of caring.
Art and science.
The ANA definition is incredibly broad but also specific. It says nursing focuses on the protection, promotion, and optimization of health, prevention of illness, and facilitation of healing. But the most insightful part is that nursing involves the diagnosis and treatment of human responses.
Diagnosis and treatment of human responses. That's powerful.
It is.
It means they're treating the patient's reaction to the disease, the anxiety, the pain, the fear, while the physician is treating the disease itself, the broken bone, the tumor.
Exactly. And that brings us to that duality, the art versus the science. The art of nursing is beautifully summarized by theorists like Jean Watson, who said that caring is the essence of nursing. This is the compassionate, humanistic side.
It's the human connection.
It is. Accepting the patient's humanity, respecting their dignity, being present in the moment, supporting the mind, body, and spirit. It's the relational aspect of care.
The bedside presence that differentiates a robot from an RN.
It is. Then you have the science of nursing, and this is where the intellectual rigor comes in. This uses established theoretical frameworks, sophisticated clinical judgment, and, most critically, evidence-based practice, EBP.
Okay, what is EBP exactly?
EBP is the systematic process used to evaluate evidence from credible scientific research and then using that research to guide concrete nursing interventions and improve clinical judgment.
So EBP isn't just checking boxes. It means nurses are now primary research consumers and data generators.
It transforms nursing from an applied trade into a scientific discipline. It's Nightingale's principle of facts, not opinions, just institutionalized across the whole profession.
And this is why nurses have to master these defined nursing competencies. Our sources list 4 foundational ones: advocacy, communication, collaboration, and change agent.
Those are the functional tools they use every single day.
And to standardize safety and quality across all the different educational programs, the profession relies on the QSA competencies, the Quality and Safety Education for Nurses framework.
Yes, and this has to be implemented at every level of nursing education.
Let's break down the 6 QSAN domains because I think they really illustrate the scope of modern practice.
Absolutely. First, evidence-based practice. Using research to inform care. For example, knowing that patient turning protocols have to happen every 2 hours, not 4, because the latest research shows better skin integrity.
Okay. Number 2.
Safety. Preventing harm. A classic scenario. Identifying a patient as a high risk for falls when they're admitted and immediately putting precautions in place bed alarms, low beds, hourly rounding, and communicating that risk to the whole team.
Third is patient-centered care.
Right. Recognizing the patient as the ultimate source of control and a full partner in their own care, respecting their preferences, their values, their needs.
Number 4 is informatics, using information technology to communicate, manage knowledge, and mitigate error.
And informatics isn't just charting. It means understanding that if you chart a patient's pain level as a 3 out of 10, the electronic health record might automatically prevent a doctor from ordering a dangerously high dose of a narcotic.
The computer system creates an instantaneous safety shield.
Exactly. The final 2 are teamwork and collaboration functioning effectively with all the interprofessional teams.
So physical therapists, doctors, social workers.
All of them. And finally, quality improvement. Using data to monitor the outcomes of care and continually improve methods. If a unit sees a rise in catheter infections, for example, QI involves analyzing the data and implementing new standards like a sterile insertion checklist to drive that rate back down.
Applying all 6 of those requires intense mental agility.
It does. Nurses have to constantly use critical thinking, which combines cognitive traits like objectivity with effective characteristics like humility. And they have to use creative thinking to generate alternative approaches when the standard plan isn't working.
And reflective thinking.
And reflective thinking, that purposeful post-action analysis, debriefing after a difficult code blue to analyze what went well and what could have been better, that continuous cycle drives improvement.
And all of that intellectual work feeds directly into this core professional concept of autonomy.
Yes. Nursing professionals have to have control over their own practice, which requires independence, a willingness to take calculated risks, and full accountability for your actions.
And that autonomy is never more critical, and I imagine never more terrifying, than when a nurse has to actively question or challenge or even refuse to follow an unsafe physician's order.
It's the ultimate test.
Can you give us a concrete example of that kind of high-stakes refusal?
Certainly. Consider a new order for potassium chloride, 10 milliQ 5E push. Potassium is extremely dangerous when pushed quickly intravenously. It can stop the heart.
Go.
Or an order for hydromorphone, 15 milligram IV push, which is a potentially fatal dose. The nurse is the final line of defense. The principle of accountability means that regardless of who wrote the order, the nurse is the one held accountable legally and ethically if they carry out an unsafe action.
That requires not just knowledge, but moral courage and professional confidence. What processes are in place to support a nurse when they have to do that?
Well, the primary protection is the Nurse Practice Act itself, which legally mandates that the nurse is responsible for their own judgment, and then standard hospital protocol mandates a chain of command.
So you have to escalate it.
You first seek clarification from the doctor. If the doctor insists, you must then escalate the concern immediately to your charge nurse, your unit manager, and potentially the hospital's risk management team. The nurse is protected by their ethical duty to put patient safety first.
And that transition from a student who relies on rules to an independent practitioner who has to exercise that kind of autonomy, that's a whole journey in itself.
It is. It's a formalized and studied journey, actually. It's well described by models like Benner's Novice to Expert model, which outlines 5 specific stages of skill acquisition based on clinical experience.
It's a useful framework. The first stage is novice. This is typically nursing students or very new nurses. They're task-oriented. They rely almost entirely on rules and checklists.
And that's a safety mechanism, not a cognitive failure. It allows them to systematically perform tasks without missing critical steps. Then they progress to the advanced beginner stage.
This nurse has a bit of experience, maybe 6 months to a year.
Right. And they start to recognize common patterns, simple problems. But they still struggle when unexpected things happen or when they have to adapt rules on the fly.
Next is the competent nurse.
Usually someone with 2 or 3 years of experience. They recognize complex patterns, they can prioritize care effectively, they feel in control of their routine but might lack the speed and flexibility of more experienced nurses in a crisis.
From there, they move into the proficient stage.
This nurse, maybe 3 to 5 years in, understands the big picture of the unit, the patient's whole trajectory. They can rapidly adapt to changing situations and anticipate needs. They rely less on rigid rules and more on practical experience.
And finally, you have the expert.
The expert.
Mm-hmm.
This nurse has extensive experience and knowledge. Their actions seem almost instinctive. They perform complex tasks seamlessly, they naturally anticipate problems, and they almost always assume leadership roles, mentoring new nurses, designing improvements.
But just getting to that novice stage can be a profound psychological challenge, especially for adult learners returning to school while balancing life.
Yes, and our sources highlight something called Shane's returning to school syndrome, which details the predictable psychological journey of an adult learner facing competing responsibilities.
It starts with the honeymoon stage, right? The initial excitement.
Right, but then inevitably they hit the conflict stage. That's when work, family demands, and school responsibilities all surface and clash. It leads to a lot of stress and doubt.
Then comes reintegration.
This is where the student begins that difficult process of adjusting priorities, shedding some non-essential roles, and mastering organizational skills like time management. And eventually they reach the final stage of integration, where they successfully merge their new professional identity with their previous life roles.
And once that intense educational journey is complete, the regulatory landscape takes over. We talked about the difference between the voice and the regulator. The state boards of nursing, Bowen, are the regulators.
Right, and they are tasked with protecting the consumers, the patients, above all else.
And they're responsible for a lot of high-stakes activities.
A multitude. They issue licenses, they determine continuing education unit requirements, they conduct mandatory background checks and fingerprinting, and they enforce the state regulations known as the Nurse Practice Act.
The Nurse Practice Act sounds like the constitution for the profession. What does it regulate?
That's a great way to put it. It's the law that defines the legal scope of practice. It mandates required education, defines the process for disciplinary action, like revoking a license, establishes the legal grounds for delegation, and sets the criteria for advanced practice roles like NPs and CRNAs.
So the professional voice is provided by groups like the American Nurses Association, the ANA, which was established way back in 1896.
Correct. And while only about 10% of RNs are formal members, the ANA is responsible for publishing the profession's foundational ethical and procedural documents.
Like the Code of Ethics for Nurses, the Moral Compass, and the Scope and Standards of Practice.
Exactly. And while they are crucial for lobbying and public policy, they have no legal power to revoke a license. Only the Board of Nursing does.
And the culmination of all this education, whether it's diploma, ADN, or BSN, is the Standardized National Licensure Exam, the NCLEX.
And that standardization is key to consumer protection. All RN candidates take the same computerized adaptive tests.
Adaptive, meaning the test adjusts the difficulty of the next question based on your last answer.
Right. The test length varies between 85 and 150 questions.
Why do they all take the same test, despite the different educational paths?
Because the NCSBN, that's the National Council of State Boards of Nursing, they set the minimum competence standards based on public safety. The goal isn't to test the difference between a BSN and an ADN. The goal is to ensure that every licensed nurse meets the same national threshold of minimum safe competence required to practice.
And the continuous professionalization of nursing is so visible in the practical innovations nurses themselves have developed to improve safety at the bedside.
A phenomenal example is Anita Dorr, who invented the crash cart. This sounds so straightforward now, but it was revolutionary.
It's a mobile tool chest.
Designed to bring all necessary emergency supplies suction, IV fluids, meds, defibrillator, directly to the patient's room quickly during a crisis, it eliminates the chaos of staff running to multiple supply rooms.
It's a perfect example of systems-based thinking applied to a chaotic environment. Another indispensable tool is the Braden scale.
Developed by Barbara Braden and her colleagues, the Braden scale is a scoring tool used everywhere to assess a patient's risk for pressure ulcers or bed sores.
And it quantifies the risk.
Using 6 objective factors: sensory perception, moisture, activity, mobility, nutrition, and friction share. And by quantifying the risk where a low score means high risk, it triggers standardized nursing precautions. It turns subjective observation into an objective, mandatory intervention plan.
And what about assessing pain in patients who can't just tell you a number?
That's where the Wong-Baker Faces Pain Rating Scale comes in. Developed by nurse Dr. Wong and child life specialist Connie Baker. It provides a validated, reliable alternative for children or those with cognitive deficits, ensuring pain is accurately managed.
These innovations were born in the hospital, but the trend has been to coordinate care beyond the hospital walls. And that's where the role of the case manager or care coordinator really expanded.
The case manager role grew primarily to manage the continuum of care, but its rise is absolutely linked to cost control. Their key functions include coordinating post-discharge care, making necessary referrals to rehab or home health, and advocating for a timely discharge.
Why the emphasis on timely?
Because the longer a patient stays in the hospital unnecessarily, that's a metric called length of stay, the higher the risk of hospital-acquired infections and the higher the cost to the system. The case manager is the linchpin balancing quality care coordination with financial stewardship.
And that risk directly impacts the hospital's bottom line, which brings us to financial pressures and safety accountability. Hospitals can face serious denial of reimbursement for preventable errors.
Right, what CMS calls never events.
What are some examples?
Our sources list clear ones: leaving a foreign object, like a sponge, in a patient after surgery. A patient developing a preventable stage 3 or 5V pressure ulcer. Complications from poor glucose control, patient falls, blood clots, catheter-associated infections.
So if a nurse's failure to implement proper protocols leads to one of those events, the hospital literally loses money.
They do. And that financial penalty system dramatically reinforces the nurse's individual accountability. Despite working in these massive, complex systems, the licensed nurse is held directly responsible for specific actions related to patient safety.
That accountability is comprehensive.
It is. It includes personal failure, like medication errors, poor prioritization, or critical procedural errors, like charting an intervention before it's actually performed. That is professional misconduct.
And speaking of accountability and risk, let's revisit the year of the nurse in 2020. While the public rightly saw nurses as heroes during COVID, the reality exposed profound systemic flaws.
It did. The pandemic exposed critical resource shortages on a national scale. Nurses were forced into these impossible ethical dilemmas, reusing masks long past their intended use, wearing garbage bags for PPE.
They were asked to violate the very infection control principles they had been taught were sacrosanct.
They were caught between their ethical obligation to care for the patient and their personal need for safety, fighting a system that failed to provide basic protections. And those immense pressures bring us back to continuous ethical responsibility.
Like the duty to report.
One of the most difficult ethical duties. In cases of impaired nursing nurses showing signs of substance use disorder, maybe due to stress or access to narcotics, all colleagues have a legal and ethical duty to report this behavior immediately.
Failure to report puts patients at catastrophic risk.
It does. And on a more modern note, the widespread use of social media introduces this constant, pervasive risk to patient confidentiality. The rules are zero tolerance. Posting any confidential patient information will get a nurse or a student fired, dismissed, and disciplined by the Board of Nursing for violating EPILA.
And finally, that principle of accountability intersects profoundly with patient autonomy.
Yes. Nurses must respect the patient's decisions, even if those decisions are medically unwise, provided the patient is legally decisional.
And what defines decisional in a clinical setting?
It means they are oriented to person, place, and time. They understand their condition, they comprehend the risks and benefits of the proposed treatment, and they are aware of the consequences of refusing it.
So if a patient with a broken leg who is mentally sound insists on leaving against medical advice, preferring to manage pain at home instead of having surgery,
The nurse has to respect that choice, provided the patient fully understands the consequences. That concept, upholding patient autonomy, even if it conflicts with the nurse's scientific judgment, is the ultimate convergence of the art, the science, and the ethics of the job.
it's the ultimate expression of treating the human response, not just the diagnosis.
Exactly.
We've covered a massive amount of ground today. We traveled from ancient healers and wartime volunteers focusing on basic survival, past the foundational reforms of Florence Nightingale that introduced data and sanitation,
Through the great public health pioneers like Lillian Wald, who established the nurse as a community advocate.
and we landed firmly in this hyper-specialized modern landscape. We've discussed the evolution from simple diploma schools to doctoral degrees, the necessity of rigorous regulation through the state boards of nursing.
And the specific application of advanced clinical skills and safety competencies like QSEN, the Braden scale, and the complex ethical environment of delegation.
The nursing profession's scope is tied directly to its foundational obligation to society, achieving the most positive patient outcomes.
And here's where it gets really interesting. We started by looking at the evolution of cleanliness and basic survival, and now we see how high-level training is absolutely critical to patient safety. The modern nurse has to manage technology, uphold the code of ethics, and collaborate effectively.
And we know that scientific advances and the ever-increasing complexity of patient care demand increase education and specialization, a need that is constantly battering financial pressures and length of stay requirements.
So, given that hospitals are penalized so severely for complications, and nurses are the key to prevention, will the modern RN eventually spend less time providing that traditional hands-on, humanistic care and more time operating as a sophisticated, cost-controlling safety engineer? If the goal is achieving positive outcomes through systems thinking and prevention, what happens to the art of nursing that Gene Watson championed, the compassionate relational essence of the job, in the face of this overwhelming pressure to be efficient and systems-oriented? That is the profound challenge facing the next generation of nurses.